Hello. First of all, thank you, Maureen and CNETS Canada, for inviting us to speak here. I'm Kathy Arbanasin. I'm a lung carcinoid patient and a neuroendocrine tumor support group leader in California. The thought here was, well, originally there were going to be three of us who were going to give this talk. And the thought was to have a couple of medical professionals and a scientist, that's me, I have a doctorate in organic chemistry, share their perspectives on lung carcinoid. Perspectives gained not as medical or scientific professionals, but as patients who have the disease. A Canadian physician who has lung carcinoid, couldn't be here today. She has given her permission to share her case history here. It seems that all three of us felt the need to use our background to learn more about lung carcinoid at various times. We can't convey a fraction of what we've learned and would like to share in the time that we have to speak here today. Thus, I'll try to give just a little bit of a background on lung carcinoid before we describe our experiences with our diseases. Let's see. One thing that those diagnosed with lung carcinoid cancer face that isn't part of the midgut carcinoid experience is terminology related to lung cancers. I guess what I wanted to emphasize here was that, like, lung cancers, carcinoids, typical and atypical, represent two of the four subtypes of neuroendocrine lung cancers. These are outlined in the following slide. The survival statistics on this slide are based on the National Cancer Institute's SEER database results from 1973 to 2004. What caught my attention in the article that I referenced there by Dr. Modlin, it's a pretty good review article on lung carcinoid that came out just last year. And it states that those SEER results indicate that the 5-year survival rate for lung carcinoid has actually gone down in the last 30 years from 84.7 to 47.3%. That's attributed possibly to better detection techniques in the paper, as Dr. Asa pointed out earlier. However, as a lung carcinoid patient, when I think of the number of times I've heard other lung carcinoid patients communicate that their doctors have told them that their lung surgery will provide a cure or that they need no further monitoring, I wonder if the decline in survival rate might not be due, at least in part, to lack of awareness of lung carcinoid's potential to metastasize among some doctors. Anyway, let's see. Okay. To go on to the next slide, accurately distinguishing between typical and atypical lung carcinoid plays a role in the cases about to be presented here. The following slide demonstrates the criteria by which that determination is made according to the current World Health Organization classification of lung tumors. And basically, one thing I wanted to point out is that Ki-67 is not involved in these definitions, even though it's mentioned by a lot of doctors and a lot of support group lists. Basically, it seems to be a pretty simple definition. It's like if you have less than 2 mitoses per 10 high-power fields and no necroses, you have a typical lung carcinoid tumor. And, well, I mean, that's the definition for the atypical lung carcinoid there. And it's like, anyway, basically, another thing I wanted to point out about this was that in Toronto last fall, Dr. Odorizio made an analogy between a sausage and a carcinoid tumor when he stated that one has to be careful of relying too much on any one number derived from analyzing a tumor. It's sort of like the number we get depends on the part or the slice of the sausage that you're looking at, and each one is different. And necroses and mitoses can differ from one part of a tumor to the next. At least a couple of our cases seem to demonstrate that small biopsies might not be representative of the whole lung carcinoid lesions. Let's see, okay. The next slide summarizes Carol's case, who isn't here. I won't embellish much on it as she isn't here. Anyway, her story is basically that not suspecting that she had a cancer, she went in for an X-ray for a fracture and soon learned that she had lung carcinoid. This illustrates a point about lung cancer in general. It is called the silent cancer. The color of the awareness ribbon for it is clear because the symptoms often don't show themselves until the cancer is advanced. Carol wished to be more certain that she was cured after her surgery, and as a physician sought more answers. Her tumor, first thought to be atypical, was found to be atypical after she got a second opinion. That illustrates that even though after the tumor is removed, if the pathologists don't take a look at the right part of the tumor, they can misclassify it. The next slide shows some of Carol's thoughts as a recently diagnosed lung carcinoid patient and practicing physician. They indicate a strong interest in spreading awareness within the medical community about our diseases. Let's see. Okay. And I mean, I'll leave that up there for a little while. I really don't want to speak for her since she isn't here. But anyway, I guess this is my case. I share many of Carol's concerns, but I got to them by quite a different route. I guess I had some other issues going on as my lung carcinoid tumor symptoms were developing over the years. I became increasingly ill, and I continued to work in research labs working around my symptoms. I guess it became pretty difficult, and actually the symptom that actually made it impossible for me to work was extreme fatigue. I mean, it was really overwhelming. I remember going to a radiology training session and just coming back just fatigued just from walking a short distance. Anyway, during the years that led up to that fatigue, I worked in the labs of a couple of endocrinologists in the Harvard teaching hospitals, and never once did I hear of the word carcinoid even during that time. Anyway, when I became too ill to work, I was a postdoctoral research fellow in chemistry, and I aimed to pursue a research career in academia and or the pharmaceutical industry. And I planned actually to work on developing new methods for developing therapies for diseases. And I had no idea that I was soon to have a cancer cut my career short and lead me to have a very personal interest in novel therapies for cancer. Anyway, I can relate like a lot of stories about the road to my diagnosis and to my medical care, but as we were preparing this talk, I realized that to like really give a good story, give a good treatment of like everything that went along with all of this would take hours. So I just can't give all of the weird stories about the doctors who didn't diagnose me and this and that. And anyway, this is the second part of the story. Well, I guess both slides show a bunch of different things, but some points that I wanted to make were on that previous slide. I was diagnosed with MEN1 apparently on the basis that I had a bronchial carcinoid and a pituitary adenoma. I eventually had the genetic test for that done at the NIH, and that ended up being negative. And that illustrates the point that bronchopulmonary carcinoids are sometimes one of the tumors involved in MEN1. I had a carcinoid syndrome with prolonged flushing and wheezing and bronchoconstriction with my lung carcinoid. I was also found to have excess cortisol production while I had the lung tumor. And actually for what ended up being a pretty large tumor, a 9-centimeter tumor, I actually didn't have very high cortisol production, and my tumor didn't stain for ACTH, so it was thought that my tumor was secreting corticotropin releasing factor, but nobody had the stain for it, so that was never determined. Anyway, let's see, and I guess less than 5% of lung carcinoid patients have one of these syndromes associated with their disease. Anyway, I was told by some doctors, even shortly before my surgery, that removal of my tumor might lead to a cure. That's probably why one of the reasons I made the statement earlier that I made about the survival statistics. My markers were also established before my surgery, and I had an octreotide scan, actually two or three of them done before my surgery. So it was found that my tumor did light up on octreotide scans, and I did have markers by which I could be followed after surgery. And for a lot of lung carcinoid patients, they don't get that. And Dr. Granberg in Sweden does recommend that that is done before the surgery. Anyway, the biopsy before my surgery also indicated my tumor was typical, and that, you know, that like when you're told that a tumor is typical before surgery, when they just poke a little part of it, that might not necessarily end up being the case. So it might not be such a great idea to feel really safe to hear that your tumor doesn't seem to have any mitoses, when in fact that wasn't the case with mine. And I guess being a scientist helped me to get better medical care once I did get to cancer centers. And once I did go to conferences, Dr. Granberg at one point recommended CD44 as a stain for lung carcinoid tumors. He said that I guess negative CD44 is actually bad, and so is positive P53, so I found this kind of scary. But I've been kind of fortunate in that my tumor has not grown by leaps and bounds, or whatever is left there is not really showing up by leaps and bounds since my surgery. And I have been on sandostatin therapy since then, and I'm kind of wondering if that has something to do with it. And there was a point where my doctors were thinking that my tumors could have estrogen receptors and all of that, because I didn't want to get into it, but I had a long history. When I coughed up blood, it was only during my menstrual periods, and you know, other symptoms like associated with that sort of thing. But anyway, I guess like Dr. Odorisio says, I've come to accept that this is a chronic disease. I could say a lot more, but I need to let Joanne have her time to talk. So, Joanne, thank you. Okay. You just go like that.
Thanks,
okay,
Kat.
sorry.
Good afternoon. My name is Joanne Ferguson. I'm a registered nurse, and I, too, am a lung carcinoid patient. In April 2002, I was 52 years old, working full-time as an RN at the time, and I seemed to have horrible shoulder pain, and I also had left flank pain at the same time that was persistent underneath my ribs. I had an X-ray done of my shoulders, and because I worked closely with a radiologist at the time, one of the radiologists stopped me in the hall and he said, "Joanne, your shoulder X-rays are so terrible for a 52-year-old woman. You really should get checked out for some systemic condition, such as hemochromatosis." So I got checked out for that, and it was negative. The flank pain persisted, as did the shoulder arthritis. And December 02, I had a CT, which showed a lesion in the left lung, and I had a lobectomy for a 1.8 centimeter typical carcinoid tumor that was located in the periphery of my lung. I had ongoing inflammation in my hips, buttocks, and shoulders, and have had ever since. In July 2006, I became very ill with a gastritis and diarrhea and lost 15 pounds in 2 months. In November of that year, my CT started to show changes in my chest. I was put on a proton pump inhibitor because of my stomach. And in the spring, my CGA was 350 and the gastrin was 237. And the oncologist panicked a bit and sent me for an FDG PET scan. And then later I realized and learned at my first Toronto conference that proton pump inhibitors affect your CGA and your gastrin levels. The FDG PET scan that I had done at the Vancouver Cancer Centre showed moderate uptake in the base of the left upper lobe and tree and bud clusters in the right lobes. In May 2008, my husband and I went to Sweden, still seeking out answers. Do I have a recurrence? Am I getting a recurrence of this disease? I had a 5-HTP PET scan done in Sweden, and it showed uptake in the base of the left upper lobe and slight uptake in the right lobe. In April 2009, my CT now shows a change in the size of nodules in the upper lobe, the lower base, along with some bronchiectasis and scarring. So the question remains, do I have a recurrence of this disease? Sorry, paper shuffling here. And now I wait. Carcinoid cancer patients seem to do a lot of waiting. What are we waiting for? Well, we wait to see a trend, as my oncologist tells me. We're waiting to see if our 5-HIAA is going up. Is our CGA going up? Do we have increased flushing or diarrhea? Every time I arrive into his office, he says, any increase in flushing and diarrhea? Well, I do have diarrhea. I have been on sandostatin for a year and a half now. And we wait for the scans. Is our tumor growing? We wait and we see. We wait and we see. And then what do? This is where it is so beneficial to be informed patients. It is of such great value to come to these conferences and find out for ourselves what the treatment options are for our particular neuroendocrine tumors. I am waiting to see where I go with carcinoid lung cancer. Meanwhile, I am waiting to get my second total shoulder replacement in Vancouver. I do not like being a patient, being on the other side of the fence. I would much rather be a medical professional caring for the patients. I was always very compassionate with my patients. Their comfort and well-being were extremely important to me. I would like to thank all you medical professionals who took the time to come to this conference today. We, the patients, need people like you to help us. Medical professionals who will listen to us, believe us, and validate our concerns. I've learned so much from coming to these conferences. Many of my questions about lung carcinoid have been answered by listening to the lectures of the specialists, taking notes, and watching the videos. For instance, I always thought and was told that you can only get carcinoid syndrome if you have metastases to your liver. Dr. Walterine stated at the Toronto conference in October of 2008 that you can have carcinoid syndrome with lung carcinoid. And Dr. Asa stated the same thing again today. Because the circulation from the lungs goes directly back to the heart, thereby releasing the serotonin into the systemic circulation. My questions on inflammation and arthritis were answered by Dr. P. Warner. He stated at the same conference in 2008 that other symptoms of carcinoid cancer are ulcers, muscle wasting, arthralgia, myopathy, bronchi edema, and hypercalcemia. Dr. Wolin stated at the same conference that carcinoid cancer can cause neuromyopathies, particularly in the buttocks, the shoulders, and the thighs, exactly where I've had all my inflammatory problems. Living with carcinoid cancer is a struggle, as I have learned from my own experiences and from the experiences of others that I have come to know across Canada and the U.S. I have been so fortunate to have a loving, supportive family and a GP who really cares. He once said to me that having a rare disease is like a curse, and I believe him. There was a time when I felt like screaming, "Is there anybody out there who understands?" And then I found Maureen Coleman and CNETS Canada. What a hard-working, empathetic person she is. Because of her and CNETs, I am now connected to many people who understand. I still have so many unanswered questions about carcinoid lung cancer. It is so important that we, the patients, with these rare neuroendocrine tumors, be our own advocates. I know that being at this conference, I will once again learn more about lung carcinoid and other NETs, and I will take this newfound information and pass it on to others in BC with the hopes of helping them be their own advocates. Thank you.
Thank you. So we're now going to break for lunch. We are slightly behind schedule, so I'd like to keep us on schedule. So we return here at 13.